Hello, everyone, and welcome to the second panel of the day, Making Cannabis Accessible to the Masses. I'm Sarah Sinclair. I'm a freelance cannabis journalist, and you might know me from Cannabis Health, where I was the editor for the last 3 years. So, making cannabis accessible to the masses. What do we mean by that? We're going to talk about how we can better engage those outside the existing cannabis community and sort of communicate more effectively to improve awareness and understanding among those who would be classed as cannabis-naive, so they don't have any previous experience of cannabis as a medicine or otherwise. We heard Mike Barnes say this morning that there's now 32,000 patients in the UK, which is great, but I think that number pales in comparison to what it could potentially be. I think Professor Barnes put it at 3 million, so we'll go with that, but it's quite considerably more than where we're at the moment. And as an industry, we're very good at focusing on the 1.8 million who are thought to be self-medicating. But by doing that, by focusing so specifically on that, are we excluding those who might not even be aware that medical cannabis is legal and has been for 5 years? So we're going to talk about how as a community and as individuals, we can better engage those patients to improve wider understanding and awareness. I'm joined by Laura Cockram, who's the head of campaigns for Parkinson's UK, Josephine McFarlane, who is a cannabis patient and marketing manager for Grow, and Berta Kaguako, who is a health and social care consultant and cannabis patient, Sarah Hamilton from EDS Support UK, and Alice Salisbury, who is a trustee for Medcan Family Foundation, a parent of a child with epilepsy, and from a background in pharmaceutical marketing. So we have actually got 5 panelists. So we're going to try and fit in as much as we can. But we really wanted to hear the perspectives of kind of Laura and Sarah from the sort of charity outside the space to get their thoughts. So I'm just going to come to each of you and ask you to do a very quick intro about yourself and your experience in this area, and then we're going to move on to talk about what some of the issues are, and then hopefully come up with some sort of tangible solutions and things that we can do to try and move things forward. We will have some time for questions at the end, so if everyone in the audience could sit tight until then, that would be great. So yeah, Laura, I'm going to start with you. Just a quick intro, please.
So Josephine and ourselves, we're going to be backup singers today and share the mic. So Parkinson's UK is a charity that supports over 153,000 people with Parkinson's in the UK and their families and carers. As a charity, we provide information and support, but we also fund research. We're the largest funders of research in Europe. And we've recently started to fund a project in particular around cannabis and looking at psychosis in Parkinson's, because there are over 40 symptoms of Parkinson's, which includes dementia and psychosis.
My name is Josephine. I'm the marketing lead for Grow Group. I'm a patient medicating for my autism, and I did my dissertation on how to destigmatize newly legalized products and medicines, so sort of the topic of this panel. And yeah, that's the main thing.
Hi, my name is Berta. I do consultancy in the health and social care sector. My background is predominantly mental health and substance misuse. But I've also got experience as a registered manager for a medical cannabis provider, and I'm also a patient myself. I've got a few complex health needs, and medical cannabis helps me to manage my symptoms.
Hi, I'm Sarah Hamilton, the Advice and Information Manager at Ella's Danos Support UK, which is connective tissue disorder. We have a lot of patients that have chronic pain but are allergic to over-the-counter medications and opioids as well. So opening up the conversation about medicinal cannabis has been really kind of changing for us, and something that we want to kind of get more involved in.
Hi, my name's Alice. As Sarah said, I'm fortunate enough to be trustee of a fantastic organisation called MedCan. But I'm also mother of Jasper, who's a 13-year-old with intractable epilepsy, which is treated with medicinal cannabis. But prior to that, well, actually it's still ongoing, I work as a marketing consultant and management consultant, including for the pharmaceutical industry. So I have experience of bringing new medications, novel medications to market, and in particular how you make the general population more aware of those medications and open to taking them.
Perfect. Thank you, Alice. I'm actually going to start with you because you, as part of your role at MedCan, recently conducted some focus group research, which I think will really set the scene for this panel and sort of give us an idea of what the general public's opinion actually is about medical cannabis outside of this echo chamber. So can you just share some of what you found during that project?
Sure. So, I mean, I think it might involve me kind of being a little bit tough in the way that I talk, and I hope nobody will be offended. But one of the first things MedCan asked me to do when I started working with them was to go out and find out what the broader community thought. So outside of the kind of cannabis circle, what did people believe about this medication? What did people know about this medication? I don't think it'd be a surprise to anybody to know that one of the first things we found is most people don't even know it exists, and they don't know that it can be used to treat a range of different things. But beyond that, I think it's important to understand the detail of how people react when they realize it is an option. And we conducted a number of focus groups with people up and down the country who have no experience of, I say most of them didn't know that cannabis medication was an option. But many of whom, or 50% of the sample, had conditions that could, in theory, be treated with cannabis, and there's good evidence that it could help them. And we spoke to them about what did they think of this medication, what did they know about it, how did they perceive the industry, and how did they perceive those people who take these medications. And I suppose the one thing that I would I'd almost like to start by doing, by using the kind of findings of that research, is to challenge this word stigma. I think stigma is a word that gets used a huge amount within the industry. And I'm not suggesting for 1 minute that there isn't some stigma around cannabis, and certainly, I mean, there's a lot of issues around racism and things like that as well. But I think the issue with the word stigma is that it implies that the problem is all with the people who are resistant to medical cannabis, that they have outdated views, they have views that are based on prejudice, or they have views that are not informed by evidence. And actually, when you speak to, not necessarily clinicians, but just, mums, dads, young people, about this as a potential medication, it's not stigma that you encounter, but to be honest, ridicule. Almost the immediate reaction is to laugh and say, oh yeah, right, medical cannabis. There is an assumption that people who are taking it are not taking it for genuine medical needs. They're taking it because they want to get high. And that is an assumption that I would say quite forcefully, I think is at the moment being perpetuated by the industry. So as part of those focus groups, we showed people a lot of communications from a number of the clinics around. We showed them what the products look like. So, we showed them the different range of products, including things like flour. And people simply looked at it and went, but it just doesn't look like a proper medication. You look at the bottle's not labelled in the way that a proper medication would be labelled. There's not enough information about it. The communications coming from not all, I should really stress not all, but some of the dispensaries, they don't look like communications that would come from a medical group. And I think an awful lot of people, when confronted with that, simply look at it and think, well, it's a bit of a joke, isn't it? And so I would really challenge, I think we like to talk a lot about the stigma around cannabis, because it takes the responsibility away from us within the community. And actually, I think we need to start talking a little bit less about the fact that it's not taken seriously by a large number of people.
Thank you. Yeah, that's really interesting. And we'll come on to, in a bit, kind of what we can do as a community and an industry to address some of those issues. Laura and Sarah, I'm going to come to kind of both of you at the same time here, because I think it's really interesting to speak to two charities from outside the cannabis space who are sort of coming into contact with a lot of patients on a regular basis. And what are the experiences that you hear from them? And, you know, is there a big interest in cannabis medicines? And what are people's concerns? Sarah, if you want to go first.
So I would say there's a really big interest. It was one of those things, it was a bit of a taboo almost within the community, and it wasn't until we said, hey, we can talk about this, we can have this conversation, and opened it up, that I would say the conversations that we've had, even the posts on social media, have been some of the most positive interactions that we've had with our community, and this big sigh of relief of, oh, actually, we've got a huge cohort of people that are using medicinal cannabis, whether it's through prescription. We do have a lot of illicit users, and most of our community are on benefits. The cost of going through a private clinic is very expensive, and they end up having to use illicitly because they can't afford the prescription. But I would say the kind of opening up of that conversation for a lot of people as well, where they're stuck in a chronic pain cycle, they've gone through Oromorph, they've gone through codeine, tramadol, really heavy, intense drugs, to then kind of go, oh, actually, there's a potential for something else, there's a potential for something that's going to help, and others within the community coming forward and feeling that they're free to talk about it and to reduce that stigma. Like you said, it all surrounds stigma, and to educate and to share patient experience has been really eye-opening for us as a charity, and something that we want to continue having those open doors, continue sharing. If someone calls up, I often manage our helpline. If someone calls up, I'm able to direct them to lots of different places where they can find out more. And it's just, you know, our basis is support. This supports our patients, and that category is like top of the list for us.
And can I just say it's so refreshing to hear that from sort of a kind of a big UK charity, because, you know, not everyone is as receptive to it, and there is still a lot of stigma and skepticism, as Alice pointed out. Laura, what about Parkinson's UK? Because obviously Parkinson's, it tends to be an older demographic. I know it's not exclusively, but that is a sort of demographic that we should be talking about.
Yeah, absolutely. So predominantly when people are diagnosed with Parkinson's, they're kind of over 65, but there are thousands of people who are working age, who are living with the condition. And I mentioned before that there are kind of over 40 symptoms of the condition, and medication is, and obviously kind of physical exercise, ways of managing the condition. But what we also see from the medication is that it can also cause side effects. I think we mentioned in the kind of the previous panel some of the horrific side effects that you can get with kind of pharmaceuticals. And as a result of that, you know, people are experiencing situations where their medication just isn't doing what it should do in terms of controlling their symptoms. And so we hear on a regular basis from our community that they are desperate for new treatments. They're desperate for that hope, really. And as a result of that, you know, we do get calls on a regular basis, emails from the community asking about cannabis, asking about, you know, what they can do. And as a result of that, we conducted a survey a couple of years ago. We had, I think, just under 1,700 people from the community sharing their experiences, and there was a real appetite for understanding more about cannabis medicinal products and actually how it could impact people's condition. What people are really concerned about, though, is that there isn't necessarily the evidence around Parkinson's, particularly because of the variety of symptoms that there are, and also to a certain extent that there is, you know, kind of that stigma, but also the medical profession as well, not necessarily understanding kind of the evidence. There isn't the prescribing guidelines there for Parkinson's, potentially because there isn't that kind of robust evidence. So I think there is an appetite from the community, and that's really what's pushed us as a charity to say we need to be in this space, we need to be having these conversations, and also we need to fund research. And so we have put 1.5 million into research that's happening in Kings, not far from here, where people are taking CBD capsules as part of a phase 2 trial to look at psychosis. So I think for us it is really important, but we're novices in this space. So you know, be kind to us, but also at the same time, you know, if we can support the work that you're doing, and if we can be part of a greater movement, we would love to have those conversations.
Yeah, thank you. Thank you so much for being here, Laura, as well. I think it's just, those conversations are so key. So just by being here, I think is a big step forward. Josephine, I'm going to come to you, and I expect you've got all the answers because you did your dissertation on this subject. So your dissertation was on how to destigmatize newly legalized drugs. What were the sort of things that came out of that? What were the sort of standout findings?
So essentially, I did my dissertation built around the SOR model. So that's stimuli, organism, and response. And so the stimuli is cannabis itself. It's sort of the products, but also all the messages about it that you've ever received. And then the organism is all the internal processes you have whilst looking at this medicine. And so it's the sort of guilt, the shame, the apprehension, all of these different things. And then the response is either wanting to try it or not wanting to try it. And my main findings were that age was the biggest deciding factor on experiences of stigma. There are so many different groups that have so many different experiences of stigma, but with age, especially with sort of the war on drugs, 1 extra year is 1 extra year of experiencing those messages. And it's there's a lot of different groups. I mean, the way I did my dissertation was interviews, and one of the things I did was show packaging of CBD products. I used CBD as an example. And I showed one kind of more medicinal packaging, and one, it was actually the Holland & Barrett Jacob Hoy one, which is sort of green with a cannabis leaf on it. Every older person, even if they were open to cannabis, when they saw that packaging, they were like, I don't want to try that. I don't trust it. I don't like it. They didn't like the green. They didn't like the leaf. And that was irrespective of their views on cannabis. They would prefer the more medical packaging. But yeah, that was the main finding of it.
That's really interesting. You know, I think most of us in the community are sort of guilty of using the cannabis leaf at some point. You know, maybe that's I guess that's what we're talking about. Do we need to rethink about how we're communicating this? Berta, what's kind of your experience as sort of a health and social care consultant and as a patient? What do you think are sort of the biggest issues in kind of increasing awareness?
I think I'm going to focus, there's a lot of reasons.
I know you've got a lot to say.
I know, yeah, but I'm only going to focus on 2 things, don't worry. Education, just as a patient as well, and as a healthcare professional, one of the things that I found quite frustrating actually was when we were trying to advocate for patients that would come to the clinic, we would often have GPs not send us summary of cares because they did not agree with the patient being put on that medication, and therefore we weren't able to safely risk assess that patient, meaning that person did not get medical cannabis from us. And there are a lot of incidences where the police, unfortunately, would confiscate a lot of medication from our patients, and I think they really need to be. Yeah, I think they really need to be made aware, first of all, that medical cannabis is legal. As a law enforcement officer, I think they should know this because they are confiscating medication that patients need and rely on. And just to give...
Sorry, could you speak closer into the mic? When you move away, we've got to turn it up. That's why the feedback kicks in.
Yeah, is that better? Yeah, okay, perfect. I lost my train of thought. What was I saying? Yes, thank you. Okay, I can see the minute taker. So, just joking. Yeah, but they need to be educated because they are confiscating medications that patients rely on. And just to give an example of myself as an experience as a patient, I feel like as patients, we need to speak up more and we need to contribute more to research so that we can empower other patients because as we're aware, it's an unlicensed medication, meaning it's not gone through enough clinical trials. Therefore, a lot of healthcare professionals will be quite reluctant to even want to engage in something that is associated with substance misuse, and there isn't really enough evidence to suggest that it's improving our well-being. And I think education around the actual medication itself is very important as well. And I just want to give a very, very quick example. So just as an example, medical cannabis, yeah, side effects, and I'm just going to go over just some very generic information. General side effects include drowsiness, confusion, imbalance, euphoria, diarrhea, dry mouth, anxiety, depression, dependence, tolerance, and cannabis hypermesia syndrome. And other adverse reactions include headaches, migraines, nausea, vomiting, and diarrhea. So just to go over the very general pain medication. So the most common pain medication prescribed in GPs is tramadol. And the most common pain medication to get over the counter is paracetamol. So just to compare the medication, opiates, tramadol, side effects, headaches, dizziness, sedation, drowsiness, constipation, loss of appetite, nausea, vomiting, sweating, muscle weakness, physical dependency, and then an adverse reaction would be nausea, vomiting, diarrhea, difficulty breathing, respiratory depression, which can result in death. And in cases of paracetamol, which you can buy over the counter, tiredness, breathlessness, blue fingers and lips, anemia, liver and kidney damage, heart disease, stroke if you have high BP, that's the side effects. And the adverse reaction is abdominal pain, nausea, vomiting, liver problems, seizures, coma, and death. So just comparing this basic medication, I think just giving people an awareness that the medication, even though it's unlicensed, the effects are, I guess, much less than what is ordinarily prescribed at the NHS. And as somebody who has taken tramadol and as somebody who has taken paracetamol, I can tell you that often, I mean, tramadol, I just don't even bother taking it anymore because I'm literally flying in a cloud somewhere spaced out. And so it's really important anyways for us to understand how the medication, basically what the medication is, the side effects of it, the adverse reaction compared to the ones that we do generally prescribe at the NHS. And then it's important for us to speak up about how it actually helps us. And in my case, when I don't have my, I'll give you an example of actually a few weeks ago. I was perfectly fine the whole day, making my way home, and then I was going up the stairs. I bent down to lift my bag, and I pulled my entire bag, and my entire left side of my body, it goes paralyzed sometimes, so it went paralyzed, and I fell onto the floor. And I was trying to get up the stairs, and I remember looking at the steps, 7 steps to my door, and I was like, oh, 7 steps, you want to do this to me? And my neighbor eventually came out, helped me, and put me in my desk because I was stubborn, I still had to work. And so within a 4-hour period, I had taken cocodamol and paracetamol to help manage my pain. And that was from about 4 till 9. By 9 o'clock, I was throwing up because I had not realized at that time that I had taken 16 pills. So 8 pills of cocodamol, and 8 pills of naproxen, it was naproxen, and 8 pills. So in total, it was 16 pills. Afterwards, I took my CBMP medication, and that medication lasted me for about 4.5 hours, and it also got rid of the nausea and vomiting. So I think awareness on the medication is really important.
Yeah, absolutely. And we know that chronic pain is the most commonly prescribed indication, the indication that cannabis is most commonly prescribed for. I think some data shows there was about 55 million opioid prescriptions last year. So there's a huge kind of untapped potential there. And on an individual basis, which I think you illustrate really well, this has the potential to help so many people. So how do we kind of reach them and make them, let them take it seriously? Sarah, did you want to come in there?
Yeah, I just wanted to touch on that, and it's really interesting when you're going through the side effects of medication, because it's something that we get asked about a lot. And also as well, in our community, we have people that have nerve pain, joint pain, muscle pain. There's all these different types of pain. So you'll go to the doctor and you'll get a prescription for amitriptyline for nerve pain. And then you'll get a prescription for, say, tramadol or something for joint pain. And then you'll get a prescription for your muscle pain, and then you'll get a prescription because all those drugs are mixing with each other. So now we need to give you, say, some omeprazole and this and that, and it builds and builds and builds to the point as well where even the doctor's like, ooh, we've got a real concoction going on here because it's just been added to and added to and added to, and the side effects are so severe. For a condition as well where movement is incredibly important, a lot of these medications make you gain weight, which is outside of your control, and then you're not able to move more, and then you need more pain medication, and it creates a cycle. And having much more education and awareness to allow patients to advocate for themselves, to go into the doctor and say, you've got me in everything, is there an alternative? There has to be something better, and feeling confident enough to go forward and say, look, have you heard of medicinal cannabis? Is this something that we can look at? Can we try out? And it might not be right for them, but allowing them the space and confidence to be able to have that conversation. And, that information there is so important to kind of say, look, I'm not just grasping at straws, I'm giving you evidence here of experience. And I think as a charity, that's really important to us as well, that our patients are able to advocate for themselves and that medical professionals listen to that and take that on board.
Absolutely. Alice, did you want to?
I think the last two speakers, both of you have just highlighted absolutely brilliantly one of the key issues that tends to get overlooked. These medications are often being, we know they work. I should really stress, my son was having 800 seizures a day, now he has one a week as a result of medical cannabis. I do not need convincing that this is absolutely a medication that works. But having said that, they are often being prescribed for very complex conditions. So we are talking about people who will often have multiple health issues as a result of having often been on other medications for long periods of time. We're talking about people with very, very complex neurological conditions. And the idea that doctors are just going to hand out something that comes in a little tiny bottle with a laser printed label with no serious information about what's in that, with often poor quality understanding and education for the doctor themselves about the side effects, because there are side effects, about drug interactions, because you're often dealing with people who are on other medications as well. It is, to be honest, laughable. No serious doctor is going to do that. And I think, therefore, as an industry, as a community, we have a responsibility to start upping our standards. We've got to give doctors the confidence, and charities the confidence to start recommending these medications. We've got to make those professionals feel confident handing out a new, unlicensed medication to some of the people in this country with the most complex health conditions. Epilepsy, nobody knows what causes my son's epilepsy, and they have no idea how to stop it. It is an incredibly complex condition that is evolving all the time. And to be honest, I don't blame his doctors for saying, I'm not going to start prescribing something when the company that is providing that will not even tell me exactly what is in that medication. They'll tell you the lead component, so they'll tell you it's got THC and CBD, and they won't tell you anything else about what's in it. There's more information on the back of, Mike Barnes talks about this a lot, there's more information on the back of a can of Coke or a packet of crisps than there is information about what's in the product that's given to my son. And I don't blame medical professionals and, say, charities and health workers for saying, well, we're sceptical about having that out, therefore.
I'm just going to quickly come to you, Laura, because as a leading charity in the UK, is that something that is a concern for you? You've mentioned that research is a big thing and the sort of lack of high quality evidence, but is it the products and how they're being presented? Do you think that we need to kind of address that more as an industry to to be taken seriously by outside organisations?
Thank you. I would say so. it's not an area that we have a great deal of experience in, and I know that the survey that we conducted when we asked people what products they took, predominantly was CBD oil. But again, I do think that there is, if we're talking about pharmaceuticals, they have to obviously have the patient information leaflets, that they have to have a clear understanding of what goes into those products. And if we're trying to make sure that there are treatments available that do have cannabis in, that I suppose are on a same level, if you like, in terms of treating people with long-term conditions, then we should expect the same of the industry at the same time. And it was fascinating, the conversation beforehand, where we were talking about sublingual, we're talking about a whole variety of other ways of trying to get kind of cannabis into the body. I'll be honest with you, with Parkinson's medications, there are still very few options. You're looking at, yes, tablets, you've got some patches, you have deep brain stimulation, but it's not innovative in what could be a really interesting space when you think of the fact that the condition has been diagnosed for over 200 years. So there definitely is the need for there to be kind of greater research, but also to think about how we can actually get pharma meds as well as cannabis meds into the body and improving people's quality of life, because that's really what we're all here for today, isn't it?
Absolutely. I'm just going to quickly come to Berta. Did you want to say something?
It was just to touch on what Laura mentioned about professionals wanting to... Do I go close? I don't know what I'm doing here. Yeah. It's just around touching on what Laura mentioned about healthcare professionals and the reluctancy for them to actually engage in something that is unlicensed. And as well, I think one of the key areas that as a medical community we need to focus on is actually formulating a treatment model that will address some of the concerns that some of the doctors have, because, there are concerns around psychological dependency, there are concerns around the heart, and a treatment model would support with integrating it into the NHS, because it has certain steps and guidelines on how to use the medication. BNF would be really helpful. I know, again, more trials need to be done before we know what medications is best for what, but as a patient, I'm aware that some of my symptoms are managed by sativa, while some of my other symptoms are managed by indica. So depending on what symptoms arise, I would need, to be crafty with my medications. And I think if somebody as a GP who's unaware of all of this, they would feel really nervous around making this decision and putting their, name to an unlicensed prescription.
Yeah, absolutely. And that's another thing, is kind of collecting patient outcomes and kind of collecting this data to show, we're sort of 5 years in now. What have we got to kind of show to people for what it's done? Alice, do you want to come in there?
I think just picking up on Bert's point as well, but both the points that have just been made, I think, are really relevant in terms of standardization. There's a real word that we don't like to use in the community, which is standardization, because I think somehow it has come out of this culture of, hey, it's all a bit free and relaxed and we can do what we want, and it's very individualized. And it is an individual personalized medication, but that does not mean that we don't need a degree of standardization. And I think treatment models are vital. I think a big barrier in the NHS, frankly, is format. So again, no doctor is going to feel really confident prescribing something where you're kind of going, well, how much of the medication gets into the patient's body is going to depend how good they personally are at grinding it and then vaping it. There's just no NHS doctor that's going to really sign off on that. They want to see a standardized format. They want to see a format that's designed around the specific conditions. So for children, we heard earlier, oils are actually not always ideal, but they're certainly, it's better than flour. There is a huge emphasis in the industry at the moment on flour, really bluntly, because it's cheap and they can market it as effectively as recreational. Being really blunt, it gets marketed as recreational. And that is hugely off-putting to the vast majority of people, and definitely off-putting to clinicians, because they look at it and they think, flour is not a standardized format. There's no, as you say, there's no standardized treatment models around it at all. And there's no way anyone is going to either start prescribing that as a clinician, or if they're kind of not from within the cannabis community, look at that and think, yes, that's a solution for me. And I think until we're willing almost to start looking at this as a proper medication, looking at sensible, but looking at, again, standardized format, standardized treatment models, we're not going to see wider uptake of this.
Yeah, I'm going to come to you, Josephine, because I think that's really, you've obviously got some really interesting insights as sort of someone who works in marketing as well, and the role that marketing can play here is so important. Well, it's massive, it's everything really. And I think, you know, what other examples can we look at? I think sort of when we had our chat earlier this week, we talked about the cosmetics industry and kind of how they've managed to sort of legitimize itself and the route that they took. What do you think, sort of as an industry, we can do, and what role does marketing play in sort of changing this narrative?
So essentially, trying to satisfy at one time the wants and desires of people that are currently medicating on the illicit market, might have done that for a long time, at the same time as people that are scared of cannabis, is pretty much impossible, which is why I personally believe in sort of a niche marketing approach, because you can't at one, if to the illicit market users, you might be seen as disingenuous, you're going too far away from that, it's very professionalized, they can't relate to it, they don't feel like it's for them. Whereas, the other side, they think, oh, this is too recreational, even though at the end of the day, everyone's medicating for what they need to medicate for. And yeah, so in my dissertation, in the sort of literature review, I looked at stigma reduction techniques that have been used previously. One of the most interesting ones is the case of the cosmetic surgery industry and tattoo industry. To become more sort of taken seriously, they used medical associations, and I think that would benefit sort of all sides of the spectrum. And so that comes in the form of regulation, proper cleanliness, the tattoo shops are sort of very clean, and having proper doctors, proper education, centralized education is a big thing. So like with tattoo artists, you have to pass exams, you have to be approved, and there's a few other stigma reduction techniques as well, so showing the existing acceptance of society, talking about experiences with, family, with police, with landlords, they're not always good, but highlighting the times when they have gone well, and showing people, for example, I can vape outside the train station and have not much issues, but it's partly because of what I look like. But yeah, there's other techniques as well, like identity exposure, that's really interesting, which is showing the variety of people that use cannabis. So that's tied to the niche marketing, where you need to show the end of the spectrum, where you've got people sort of later in life where that really benefits, where they've got more medical issues, but then also younger people, for example, there's an increase in diagnosis of neurodivergence, especially in young people, and marketing to each of those specific groups, I think, is what the industry needs to be doing, and not picking one or the other, just sort of, niche marketing approach is best, because if you try and mass market something that's so complex, you end up marketing to no one, and everyone's put off.
That's a really interesting point. Yeah, thank you. I've got 2 minutes, so I'm just going to very quickly, I wanted to sort of come to each of you for a key takeaway of kind of what all of us as individuals can do, sort of leaving here today to try and tackle this. Obviously, it's really, really complex. There's so many different aspects to it. But I suppose, yeah, just one little thing that we could all do. I'm going to come to you first, Laura.
I think collectively come together. This is a great start, but it's about thinking about how we can get more people together to have these conversations. And then it's also about sharing stories and sharing the diversity of stories. We did some research last year about a campaign to get more people involved in research, and we tried doing it last year around numbers, but actually that didn't work. It was the personal stories that really impacted, so I think that's really important.
I was going to say the same thing as sort of Dr. Callie was talking about at the start, where, you know, I like to start conversations even with my postman when he delivers my medicine. I'm just like, guess what's in here? And, you know, telling them, just telling absolutely everyone you can, but then also it's a bit risky. It depends who you are. So, you know, me as a white woman, I'm much more able to do that. And in the sort of circle of your family and friends and, you know, even talking to your grandparents, I think is really key. But yeah, talk to everyone, essentially.
Similar to what you said as well, research is really important, but also for me the key area is formulating a treatment model so that even naive patients, when they go to a private clinic, they are given some form of a treatment plan of how they're going to address their condition. And so that will help with a lot of prescribers within the NHS and a lot of cannabis-naive patients as well, to feel more comfortable knowing that they have something to, I suppose, achieve or attain to.
Similar sentiments in terms of talk, but talking as well in terms of accurate, factual information, because that reduces the risk of that conversation, you know, falling apart. So I'd say the biggest thing was, sharing factual information, but sharing it far and wide.
Actually, I think Josephine just hit the nail on the head a moment ago when she said there's this split between an industry that is trying on the one hand to appeal to the legacy market and on the other hand trying to open itself up to a wider organisation. And I suppose my last thought would be, I think we have to confront that head on. I think that the industry has to accept that it can't keep twin tracking, it can't be asking on the one hand to be treated like other medications, while on the other hand wanting to act like it's effectively still an illicit or illegal product and have all those sort of marketing side of things and all that terminology and all that iconography. At some point, the industry is going to need to pick which of those two business models it wants to pursue. As someone with a very, very sick child, I really hope it's the former and it's a grown-up medication, because there is no way the NHS is ever going to prescribe this while we're pursuing the latter of basically still behaving like it's recreational.
Thank you. We're going to open it up for a Q&A now. I can't really see much, so I'm hoping that somebody else is going to help me out there.
Okay, so this is less of a question and more of a comment, because they talk about the side effects and the labels. I think is really important, especially for women consumers, to try to get away from that stigma, because I don't know if any of you have ever opened up the side effects and warnings on birth control pills, but they're like a map when you fold them open. So I think that we should be having that conversation and bringing more women into the fold of cannabis use, and the ones who are naysayers that, you know, have that birth control pill discussion, because the side effects and warnings are terrifying on those things.
Yeah, I think that's really important and something we haven't really touched on too much, but the need for the industry to talk about the negative side effects of cannabis as well, because I think then we avoid this sort of, it's a snake oil sort of path. Yes.
Thanks, hello. The question I have is that, if I'm honest, the legalization of medical cannabis is actually quite new to me. I've been working in addiction for 15 years, and I can guarantee that even my colleagues now are probably not even aware of the law. I just want to know why it feels like it's a secret. Like, why is it not publicized more that it's availability? Because I also educate around cannabis in schools, colleges, etc. And so one of the things we go through the law, and I've been saying for some time, Class B, end of story. But obviously it isn't. So I'm just wondering, why is it kind of hidden, the legality of it?
Yeah, go for it.
I personally think that it's a lack of centralized education. I think that education around cannabis is so decentralized. You know, you've got patient groups, you've got clinics, everyone's, you know, contributing a little bit, but there's no one sort of key main resource that doctors can use. It's not sort of out and about in GP surgeries. There's not reliable referenced information, and there's not a push for that for many, many different reasons. The rollout's been sort of very slow, but hopefully, fingers crossed, it won't be that way very soon. I think it just needs a lot of collaboration and commitment from doctors, but then that will also the industry acting well for doctors to take it seriously?
I mean, this was actually something we did address in the focus groups that we conducted. And I think there is a kind of cultural issue in the UK very specifically. We have the NHS, and there is a huge amount of respect for the NHS. And there is an expectation for people that kind of, within this country still, that the reliable information and the reliable medical advice comes from the NHS. And anything that is happening outside of the NHS, I think for the mainstream, is automatically niche and a bit weird. And I think really honestly, a lot of the shift is, that kind of big mass movement shift is only going to come from getting NHS endorsement, because we do still within this country, we love that institution, we respect it, we're proud of it, and they are the authority figure on this. So I think the fact that it's not within the NHS immediately sets up barriers for people, and also means they just don't look for the information.
Yeah.
Yeah, that's a good point.
Yeah, we can't advertise.
Yeah.
I don't know.
Hello, this is directed to Sarah. We're both EDS patients, and I had to learn how to medicate myself before legalization. Given the comorbidities that we suffer, given neurodivergence, all the there's so many things that cannabis can help us for. I have damage from every single pharmaceutical that I have been prescribed, some of them quite seriously long-lasting, including cataracts that I'm awaiting surgery for, and other surgeries I'm waiting for. What can we do, research-wise, to ensure or change things so that cannabis can be prescribed as a first-line medication, so that we don't have to go through this route and experience the damage that people like myself have got?
And that's a really excellent point, that damage that is done. Why, as a patient, have you got to be subjected to that before coming to something that is going to work and that you've had to discover on your own? One of the biggest things for us at the minute is awareness of the condition from the get-go is terrible, it's poor. You go to the GP and they're like, no idea what you're talking about, or you're just a bit bendy, there's nothing wrong with you, move on. You were gaslit, you were disbelieved, and then when you do get something, they just throw everything at you. So personally, from kind of our charity perspective, is from the get-go, if we could do training, and this is something that we've been discussing, if we could do training with those primary care physicians about the condition, about the side effects of medication, about the comorbidities, and like you said, there is a long list of things that tie into Ehlers-Danlos syndrome, that would open the door for the conversation of actually, this would be a more appropriate step to take. So we've got a campaign going at the minute. We're in Westminster in a couple of weeks, and it's basically that, to provide education for primary care about the condition, but how to treat it and how to treat it effectively.
Yeah.
Some questions. Oh, sorry, it's surprising. We've got a question from medbud.wiki. I think you might have a comment against this. When 90% plus of prescribed patients right now use flower, should we not be focused on the fight for clinical acceptance of flower?
The thing is, right, when it comes to medication, everybody responds differently to different types of medication. So I don't particularly feel that we should be advertising or pushing for a specific medication. I think we should be pushing for all of them, because everybody is going to need something. Like, for instance, I can't use oils. Oils upset my stomach, I start throwing up, so I require flour, whereas another person feels very sick with flour, so therefore they would require an oil. I think earlier somebody mentioned capsules. I would love to take a capsule. I don't want to be vaping all the time, but I can't take oils, so if there's a capsule available, I would love to take that. I don't think that we should be pushing any medication in particular. We have to push all, because, you know, patients at the end of the day benefit from so many different strains, and we need to have as much availability for them, because like we mentioned, a lot of the patients, especially like myself, we've got comorbidities, and with the NHS, I think I was on about 6 different types of medication to manage my conditions, whereas now I'm on 2 strains of one medication to do the same work. So it goes back to the point that you were making around educating that, you know, that the benefits of using medical cannabis rather than putting a patient through 6 different types of medication that can cause you to feel discombobulated. I'm not going to go on a rant, but yeah, I think we should just, we should focus on pushing all of the medication. It will benefit a variety of different people.
Absolutely agree. I think the answer to that is if you want to be treated like proper medication, you need to have options that are appropriate for individual conditions. You can't treat it as one size fits all. There is no other medication that does that. But I would also stress, just from a professional point of view, with experience of how you bring new medications to market, why on earth would you focus on the thing that is going to be absolutely the hardest thing to get through clinically? If you want to break down barriers, start with the easiest things to get through. Start with acceptance of oils, start with acceptance of, we call them edibles, don't call them edibles, call them capsules, call them tablets. Start with things that we can get through that will start to open up acceptance, and that will lead to acceptance of flower. If we keep pushing acceptance of flower, you're going to be 50 years before this is licensed and available, because there's no model for that. Sorry, I get a bit angry about it, so.
Hello, thank you for the panel. I'm just asking about whether you think there is a way forward to have the medicinal and pharmaceutical market, but alongside a recreational, perhaps herbal market, with the caveat that there are so many patients who are experts in their own conditions. I understand, Berta, you were saying how you have to be a bit crafty with your medication if you need sativa for certain symptoms and indica for others. I'm exactly the same. I know many people who take cannabis illicitly who are exactly the same, who want to understand more, who want more monitoring, who want to be able to access better strains. But if we don't have a market that looks at the expertise that is available within the public and within patients who've been taking this for decades, for years, we're not going to be able, and at the same time, we're excluding patients from research who have been taking this for a long time, I have a lot of questions about this because there are so many different parts around this. Like if we look at the study that's happening in King's, where they're trying to recruit so many patients, but they cannot recruit black and brown patients because of the stigmas that they face more than white patients, and that they will be more marginalized with the research that comes out of it. And that in all this time, we don't include the most marginalized groups who are the ones taking this within the research, and we don't allow their voices to be heard. And in that sense, we further marginalize them. And when we talk about the illicit market in a way where we are ourselves further stigmatizing them, saying that we shouldn't be including them, we should not look at how we market towards them, we should focus it directly just on the medical side. We are completely divorcing ourselves from a group that have so much knowledge and that we could be taking, a lot of expertise from them. So I'm asking, is there a way that we can do this hand in hand? I'm not sure if there are other countries that have done a similar approach, but I assume there are. But is there any way that we could do that?
So, yes, that one is going to be difficult. I understand what you mean by having the need for flower, because yes, a lot of people do use flower. And I'm just going to give an example from the substance misuse sector. When we, in that sector, there are some patients who are so used to injecting heroin that they struggled with methadone. And as a result, we prescribed them then diamorphine, which is an injectable version. And the whole purpose of it is because they're so accustomed to injecting that it became a habitual practice for them. And so I understand what you mean in terms of still having that flower availability, because there are people who do smoke it, and therefore they would feel more comfortable moving from I suppose illicit to more medical use if it stays as something that they're familiar with. But the reality is that at the same time, this is where I suppose, and I am so sorry for saying this, but this is where sometimes institutional racism comes into it as well. Because I'm going to give an example again of myself. I'm a working professional. I'm a black woman. My colleague is also a working professional, and she's a white British woman. The both of us, medical cannabis came out around the same time, came out, and we both joined, and I think a week apart from each other. And she went to her GP, and her GP said to her, tried to discourage her, but at the end of the day, it was the end of that. I went to my GP and a safeguarding alert was raised. So there is also the fact that a lot of black people, they're not going to want to feel comfortable going to their GP and saying, do you know what, can you prescribe me medical cannabis? Because of our skin color, unfortunately, a lot of the times people will just be like, oh, well, you're just using it illicitly. And let's not forget that the BAME community as well, when it comes to mental health, there is a huge stigma around mental health. So when they are misusing in order to self-medicate, they won't even acknowledge that they're misusing in order to self-medicate. So it makes it more trickier for them to get that mental health support as well when they're not even acknowledging that they're using it to self-medicate. They will just say, oh, we just use it to chill and relax. But the reality is that they are self-medicating and they would benefit from it. So I think education around them understanding that you're actually using to self-medicate and that there is a way that we can do this safely as well to support you. And again, this goes back to the whole treatment plan as well, and addressing a lot of the barriers that a lot of different patients from a variety of demographics will encounter, unfortunately, just because of the way society is set up. Sorry.
Thank you. No. Yeah, thank you so much. Thank you for that question, and thank you so much, Berta, for sharing that example, and please never apologize for bringing that up, because it's so important, and I think it's actually a really good way to end, because it's something that we all need to go away and sort of think about more. We're a very kind of white industry still. There's a lack of representation in the patient group of kind of patients from ethnic minorities, so I think, we need to, I wish we had more time to speak about that now, but just, yeah, let's end on that, and let's go away and kind of make some change by lots of talking.